morning. We gotta get started. We're doing 2 lectures today, PCOS and infertility. So let's go. Anybody a Medea fan? I love Medea. Medea. She's so white. Medea. And this is perfect for PCOS because Medea is so PCOS, right? If it was really a female, it's not. And Medea, so we go to Myrtle Beach every year for a couple weeks and hang out on the beach, which is the best time of my life every single year. And when we go through Georgia, and Medea, you know, as you guys know, if you know Medea, she can't be in Conyers, right? I think that's her thing, is like she has to get back. Does she have to get back to Conyers or she be in Conyers? Something about Conyers, Georgia is her thing, where she would go to jail in Conyers. So my kids love Medea. They watch the Boo 1, the Boo 2, when Medea goes to jail. Watch all of this. We are definitely Medea fans. We like them. Right. We'll talk about PCOS. Let's do a review question. 22-year-old comes in with bilateral breast tenderness for the last 3 to 4 months. Symptoms appear worse just prior to the menstrual cycle. It's got tenderness in the upper outer aspect of bilateral breast with a ropey feeling on exam. What is her most likely diagnosis? Fibrocystic breasts, right? Because fibroadenoma is going to be a solitary, kind of rubbery feeling. Mastitis is an infection. Breast abscess will probably be pretty symptomatic with redness, maybe fever. And then nostalgia. The nostalgia is diffuse bilateral breast pain, but we kind of think about it as cyclic versus non-cyclic. This could be something like a cyclic nostalgia. But usually on exam for nostalgia, you're not going to have any abnormal exam on nostalgia. It's just going to be diffuse breast pain. We see that a lot more in kind of perimenopausal and menopausal, particularly menopausal patients. All right, so fibrocystic breasts for this age group. 34-year-old comes in with right breast discomfort, physical exam. There's a 3 centimeter mass at the 11 o'clock position, about 3 centimeters from the nipple. What is the next step for evaluating this patient's complaint? Mammogram, right? Do you agree with that? Mammogram. So over the age of 30, mammogram. Under the age of 30, ultrasound. You gotta know that. We already talked about it. Is that 100% all the time? Absolutely it's not. But for our purposes, it's what, when you order something, you want to think about over the age of 30, it's probably going to be a mammo. Under the age of 30, ultrasound, because of the change in the breast density. And you'll oftentimes miss something if you order a mammo on a younger person and ultrasound on an older person. We get super lucky because when these patients go get a mammogram or an ultrasound, if they need additional studies, most of the time those breast folks are going to order those studies, or they'll send you something in MHS tennis and say, I recommend that you order this. For the National Guard Reserve folks, it might be a little bit different, but usually on the outside, they will send back to you that order of these images what the next recommended imaging is. But for over the age of 30, we think about mammo. Under 30, we think about ultrasound. PCOS. So PCOS was actually first described by Doctors Stein and Leventhal in 1935. And what they did is they collected a series of patients. These patients had irregular menstrual cycles. They had some sign of hyperandrogenism, so a little bit of excess facial hair, and they happened to have cysts on their ovaries, multiple cysts on their ovaries. And each one of these patients underwent a wedge resection of those ovaries. So they took like a pie-shaped piece out of the ovary, which ultimately removed some of those cysts. And once they did that, they returned to having normal or regular menstrual cycles. So they said, oh, that must be the problem then. These cysts must be all of the problem that's causing all of these things. It's causing hyperandrogenism, it's causing the abnormal menstrual cycle. So if we do wedge resections in all of these patients, they'll probably return to completely normal with their cycles and less evidence or less virilization. But realistically, that's probably not the case. They did do wedge resections for these types of patients for many years. For probably, so this is 1935, so for probably 20 or 30 or 40 years, they treated these patients with wedge resection. But ultimately, ultimately, I think they determined that that's probably more coincidental than it is a causative agent. Because there are people that have polycystic ovaries, but they don't have these other symptoms in association with it. So we think of polycystic ovary syndrome as a multi-system kind of endocrine disorder that affects about up to 5 to 10% of reproductive age women, 1 in every 10 women worldwide. And it is the most common cause of infertility that we're going to see. So you need to have this on your radar when patients come in. Their primary complaint is infertility. It's a condition where we have the ovaries that produce abnormal amounts of androgens. Okay? And that's that male sex hormone, which accounts for a lot of the male features that we see as far as excessive hair growth. Clitoral sometimes we'll see with this as well. Many times these patients with PCOS, the PCOS is not their only problem, right? So they develop other chronic medical conditions associated with this. Insulin resistance, where they can make insulin, but they can't use insulin appropriately or effectively. They oftentimes get dyslipidemia, so an increase in their lipids. Okay? Heart disease, that was from the insulin resistance and the dyslipidemia. They can get fatty liver disease that's associated with this. Depression and anxiety often goes hand in hand, especially in those patients that have severe PCOS with severe outward signs of PCOS. Okay? They can get eating disorders because oftentimes these patients are overweight and they want to lose weight. It's very difficult for them to do that, so they'll start doing binge eating or become anorexic. And a lot of times these patients have difficulty sleeping because of the increase in estrogen and circulating androgens that's associated with this, and of course the anxiety that's associated with this as well. The problem is it's hard to treat because we don't really know the cause. We think it's probably multifactorial, environmental changes, probably a familial or genetic predisposition, because we do see that it occurs within families and first-degree relatives. Things like poor diet, obesity, they can lead to excess androgen secretion from the ovaries and the onset of insulin resistance. We think about lifestyle changes, so things even like secondhand smoke can cause increased chance or have been linked to patients with PCOS, okay? Or excess androgen production. So we think, again, familial probably, but also some environmental changes or conditions that increase a person's chance of PCOS. And the pathophys is super complicated, right? I actually saw a patient on Monday. I looked in the ER, and this patient came in to see me because she was having an endoscopy, a colonoscopy, and a colposcopy the next day. That's a lot. That's a lot anyway. So she was a young patient. I think she was 29 or something. And I was like, what in the world is going on? You're awful young to have all these things. And she says, well, I have been seen by OBGYN for amenorrhea. I haven't had a menstrual cycle since I started basic training. So before basic training, had normal menses, no problems. But since then, no menstrual cycles. And so they've been working her up. And they did a bunch of labs on her. And what they found is one of these things. They found that her LH is twice as high as her FSH. So now she's coming in to get additional labs before surgery. I mean, some stuff she really didn't need before surgery, but things like DHEAS, testosterone levels, because they're trying to identify the problem. But the issue is she's been seen probably 6 times already. They're thinking she has PCOS, but it's not just a lab component or a physical. She had no excessive hair, but she also had no prior pregnancies despite unprotected intercourse. So as a primary care, this becomes really difficult because she's seeing the specialists and they are multiple visits into this and can't figure this out. So when we think about PCOS and the pathophys associated with this, there's a lot of labs that are associated. A lot of labs we have to think in our mind that we have to do. If we start all the way up at the hypothalamus, we've already got a problem from the hypothalamus where we have inappropriate GnRH secretion. Okay, normally we have that pulsatility, but now it's not doing that for some reason. It's either too much or too little. What is that going to affect? Well, that's going to affect the pituitary, right? And what do we have coming out of the pituitary? FSH and LH. So that FSH and LH ratio is going to be off. LH twice as high as FSH, okay? Twice as high. Do you see that highlighted? Do you see me saying that to you? Okay? Twice as high in 50% at least of these patients. And that's one of your first clues, because oftentimes you will do these labs in a patient, in addition to thyroid, in a patient that comes in with amenorrhea, secondary amenorrhea. So then we come down from our pituitary. Well, if we don't have or have abnormal secretion of our LH and FSH, that's going to affect the amount of estrogen and progesterone that is released as well. Okay, so really, we have elevation in serum androgen production, and those androgens and the conversion to estrogen happens out in the adipose tissue. The majority of these patients are obese, they're overweight. So now we have excess production and conversion of those androgens and estrogen. So then we think, well, is it the obesity that's causing this androgen, excess androgen and estrogen production? Or is it the excess androgen and estrogen production that's causing the obesity? We don't really know what comes first, the chicken or the egg. We do know that when we look at these labs and the component of these labs, it's not just a snapshot in time. It's over time that we have to look at these things. We get one set of things that are abnormal, that leads us to another set of things that we need to evaluate. Okay? So the pathophys is pretty complicated, which again is why it's difficult to really treat these patients. And oftentimes it takes months and months and months to actually diagnose something like PCOS. Clinically, the presentation can vary from patient to patient. A lot of these patients do have some degree of hyperandrogenism. So they're going to have excess hair, excess acne, deepening of their voice. 90% of these patients will have some sort of menstrual irregularity, right? But with these patients in a situation where they're going through basic training and AIT in their late 20s, that's not unusual to have menstrual irregularity. Only that's going to kind of work its way out. Okay, so in the military system, a lot of patients, a lot of females will have menstrual irregularities when they're going to training events or they're deploying because of the stress on their body. The ultrasound, a good portion of the time, the ultrasound does show polycystic ovaries, okay, but not always. Okay? About 75% of these patients are going to have infertility, and that may be the reason why they're coming to see you, because of the infertility. And 65% have some degree of obesity, so they're overweight to some degree, usually as a result, or ultimately can cause insulin resistance. So on physical exam, these patients often will have an elevated blood pressure. They often have a higher BMI. They often will have a bigger waist circumference, and all of those things increase their cardiovascular risk. So we want to make sure that, especially in patients that are diagnosed with PCOS, we're monitoring those things. We're monitoring their blood pressure and their BMI and their waist circumference. Again, we're looking for evidence of hyperandrogenism. We're looking for that excess acne or excess hair, hirsutism, maybe male pattern baldness that we can see. And then we're also looking for evidence of insulin resistance. You may or may not have seen this in dermatology already, but that's that darkening of the skin, oftentimes at the neck. You can see it in the axil, you can see it in the anterior neck. That's called acanthosis nigricans. Okay, so that's what we're looking at. That is direct evidence of insulin resistance. You can see that in young folks and older folks. PCOS is considered a diagnosis of exclusion, meaning there's a lot of things that look like PCOS. So we've got to rule those things out before we can say, yes, this is definitely PCOS. There's no universally accepted criteria that say, if you do have these things that are positive, this is PCOS. But the majority of people, including American College of Gynecology, will use what's called the Rotterdam criteria. According to the Rotterdam criteria, you need to have 2 out of 3 of these components to say that they are more likely to have PCOS. So some sort of menstrual irregularity, Polycystic ovaries, evidence of hyperandrogenism. Those are the three things that we're looking for. Okay, so let's delve into those a little bit. If you think about menstrual irregularities, amenorrhea, so at least 3 months of no menstrual cycle in a person that was previously menstruating normally, or 6 months in a person that had a history of irregular menstruation. That is the definition for amenorrhea. Infrequent menstrual cycles. These patients are typically having 9 or fewer menstrual cycles per year. They've got more than 35 days in between their menstrual cycles. And oftentimes, this can be a cause of primary amenorrhea. We see this in younger folks where they don't even start their menstrual cycle. We've talked about that already as one of your differentials for primary amenorrhea. Okay, so this can certainly occur, and occurs as a part of anovulation. Hyperandrogenism, that can be clinical where I can see it, or it can be biochemical. I see it on the labs. Okay? So clinically, we're looking for that excess hair, we're looking for excess acne, maybe this male pattern baldness. We may have the linea alba is a line that goes up the middle of the abdomen. Sometimes it'll have a hair in the middle of the abdomen that's coming up. Other features that may signify that this is not PCOS, but maybe even an androgen secreting tumor, because that should be under different, really significant deepening voice, clitoromegaly. A bearded lady, we kind of think of this as. So many years ago, they had these people in what? What is that mean? In the circus, right? In the circus. Anybody been to a circus lately? I don't have so many circuses anymore. Occasionally, but I don't think I've seen a bearded lady recently. But when I was a kid, for sure, I saw that. Right? Labs. Okay, so maybe we don't see anything clinically, but labs. We're going to look for that free or total testosterone. Okay? And check those labs that's associated with that. And that's exactly how you order. You order total testosterone, you order free testosterone. Okay? Polycystic ovaries is another one of those Rotterdam criteria. So we're looking for that on ultrasound, usually transvaginal ultrasound. And specifically, they're looking for 12 or more follicles between 2 to 9 millimeters in both ovaries. Both ovaries. Not one ovary, but both ovaries. Or they might just have an ovary that's enlarged, greater than 10 centimeters, so it's full of kind of fluid. It's edematous. And we're not talking about in the setting of these patients are exposed to fertility treatment. Right? So this is an enlarged ovary by itself. So those are the two different ovarian pathologies that we might see on the ultrasound. The problem is that polycystic ovaries can occur outside of PCOS. Okay? Up to 50% of patients that have normal menstruation, they don't have any evidence of hirsutism, they have polycystic ovaries. Okay, so do they meet criteria for polycystic ovary syndrome? No, they don't. They have one thing. And so you can have polycystic ovaries outside of polycystic ovary syndrome. But again, about 90% of patients that have polycystic ovary syndrome do have associated hirsutism. They do have some sort of menstrual changes, and they have polycystic ovaries. But you can see it outside of PCOS. And again, because this is a diagnosis of exclusion, you've got to have a very wide differential when these patients are coming in with menstrual irregularities, or I've got hair growing out of places I never had hair growing out of. Right? Thyroid, hyper and hypothyroid can cause menstrual irregularities. Okay? They can cause, intermittent problems with ovulation. So there's nothing wrong with doing a thyroid function panel on these patients. TSH, free T4, T3. Hyperprolactinemia, that can also cause problems with ovulation because it affects estrogen and progesterone production. So nothing wrong in the right patient avoiding a prolactin level. Okay. What about non-classic congenital adrenal hyperplasia? How might those patients present? Certainly menstrual irregularities. We also think about probably a little bit of evidence of hyperandrogenism. So we could do a morning 17-hydroxyprogesterone level. If that is normal, and you guys probably already know this, but if that is normal, there's almost always recommendation for a follow-up ACTH stim test that's associated with that. So that's kind of a two-part, even if it's normal. If it's abnormal, you don't need to do the ACTH stim test. Again, if they have an androgen-secreting tumor, usually they have a lot of excess hair, really clinical evidence of significant hyperandrogenism. And I did see a patient maybe about 6 weeks ago that had this. She was a young college girl, and she came in because she had fallen, and she used to scrape her entire face up. But she had almost a full beard, full chest of hair, and of course was diagnosed with PCOS. I suspect she probably had something more than that, but her parents didn't want, and she, I guess, ultimately didn't want any sort of treatment. And so that's just how she lived. But I don't know if she had anything else. They said PCOS, but completely untreated PCOS. But this is what she looked like, full beard and even chest hair growing out of her shirt. So this is uncommon to have an androgen-secreting tumor. Again, most of the time on physical exam, it'll be obvious, like this is a lot of excess hair. But if you think about a patient like an Asian female, Asian males, they don't have a lot of hair. Okay? So they could have an androgen-secreting tumor and just have a little bit of hair, but you're like, oh, that's not enough. I mean, you should have like a beard or something, right? But not necessarily. So you've got to think about genetics as well for some of these patients. Okay? But if it's something you suspect, then we're going to free testosterone, or total testosterone in these patients. Cushing syndrome, again, very rare. We think about Cushing syndrome as a classic moon facies. They got the hump on their back. They've got the striae that looks like it's bruising within the striae. If there's anything and the patient comes in and they look like that, then we usually do like a cortisol level on these patients. Okay? So again, your differential is huge. So that's what makes this a big lab component. Okay? We talk about this being a kind of a challenging diagnosis and a diagnosis of exclusion. So we start bringing our labs in to our evaluation of our patients, not just our physical exam or their history. That's why we talk about TSH, we talk about prolactin level, LH, FSH, total and free testosterone are in there. And don't forget that these patients oftentimes are reproductive age. So we've got to put a pregnancy test in there as well to make sure there's no complications associated with a pregnancy. And so you don't need to know all of these labs. There is some stuff down at the bottom that's kind of highlighted. Know that this is a diagnosis of exclusion. There's a lot that's associated with this. No, LH and FSH are kind of one of your main components. And if that's twice as high, LH twice as high as FSH, that is your indication that you've got to do some more labs on these patients. Usually a total testosterone, free testosterone, and DHES are going to be next on the list. Okay? So how do we treat this? Because we don't really know the underlying pathology. It's really a multimodal process. I'm going to attack this in different ways to address the patient's symptoms altogether. But the first line treatment we want to talk to our patients about is lifestyle modification. Okay? Diet, exercise, weight loss. Even if they're able to lose about 5%, okay, so 5% weight loss, a lot of times that is enough for them to resume normal menstrual function. Okay, so we want to talk to them about that first. Remember that if patients are having irregular menstrual cycles, that is an indication of anovulation. Patients that are chronically not ovulating are at increased risk for endometrial cancer. PCOS patients are at increased risk for endometrial cancer because most of these guys are not ovulating. So we want to try to protect them from that. We want to do endometrial protection. We can usually do that with something like combined oral contraceptives, or we could use progesterone only. Remember, combined oral, we got estrogen and progesterone. Nice thing about the COCs, the oral contraceptives, is they help in treating the hirsutism and the acne as well. They bind to excess circulating androgens, and that decreases the amount of free testosterone that we have. So that's nice about that. The good thing about the progesterone component is it keeps the lining of the endometrium thin. So they're less likely to develop endometrial cancer because we have that thin lining. Endometrial cancer occurs because of the thickening of the lining and excess of our estrogen. And then Patients that with PCOS that want to conceive oftentimes have a difficult time doing it. We've already talked about 1 in 10 patients come in for infertility. So we want to talk to them and maybe help them with their fertility issues. Certainly weight loss, which we already talked about, but a lot of times medication component is part of this. Something like letrozole or clomiphene citrate. According to the American College of Gynecology, these are going to be your recommended first-line treatment for anovulatory infertility. So they're coming in with those irregular menstrual cycles. That is your indication that they're not ovulating correctly, and this will be your first line. Oftentimes, we will add metformin to that. Because metformin not only helps with fertility, it also helps with our elevated insulin, so our insulin resistance, and the diabetes component of this. So diabetes component, metformin. There's other things out there now that are recommended that these patients can go on, the GLP-1s, the SGLT2s. They can go on either one of those, okay? And then if that does not control their sugars, then they may, in turn, have to go on insulin. That's usually several months down the road. Because these patients are at increased risk for cardiovascular disease, we want to make sure we check and manage those lipids. Okay? So screen and treat for dyslipidemia, and you can put patients on those medications. Hirsutism. Okay, these patients probably want treatment for excess of hair growth. I almost guarantee it. So we talked about we can do that with combined oral contraceptives. Do combined oral contraceptives get rid of the hair that's there now? No. They help prevent additional hair growth in months from now, usually 3 to 4 months. Okay? We would start to see a decrease in hair growth, but it doesn't prevent or doesn't get rid of the hair now. So if you put someone on a combined oral contraceptive to provide endometrial protection, ultimately we'll get the secondary benefit of decreased hirsutism, acne, and they're 6 months in, and maybe they are now having normal menstrual cycles, but the hair is still there. The hair still seems to be growing. You could add another medication. You could add something like spironolactone. Okay? That decreases the amount of testosterone that's being produced. And also increases the clearance of testosterone. So that can help with that. But for hair now, we think about topical medications, something like eflornithine. Okay, eflornithine helps slow the hair growth. It does not get rid of the hair. And then once you stop eflornithine, the hair can come back. So we also think about laser hair removal, electrolysis. Are those 100%? No, they're not. And anyone that's had laser hair removal, you'll want it because it's super, super expensive. And in your mind, like, I hope this hair never comes back, but unfortunately it does. But just at a much slower rate and not as thick and not as much hair. Those are things that you can refer your patients for. Always remember, when you're doing these consults, it's about how you write the consult up, if it's going to be approved or not. So you've got to talk in these consults. Sometimes you got to beef it up a little bit. Person has significant hair growth and is causing significant depression and anxiety that's associated with, please consider evaluation and treatment to ultimately help this patient out in a total fashion, not just the hair growth itself. So our focus then for our treatment goals is really we've got to control that menstrual irregularity to decrease their chance of endometrial cancer in the long term. We want to help these patients, and if they want to have children, we're going to help them with that by talking to them about lifestyle modifications that are potentially prescribing. You can prescribe things like clomiphene and letrozole. You can prescribe that from a primary care standpoint. That is not a problem. We want to certainly control their glucose if they are having issues with insulin resistance, which most of them eventually will. And then treat and control their hirsutism, their acne. Long term, if we can do those short-term goals, we can reduce their cardiovascular risk. We can try to control their diabetes that they're ultimately going to get, and reduce their chance of endometrial cancer. And then there's nothing wrong. These patients, again, oftentimes will have problems with depression. SSRIs work really well for that for these patients, as long as they have no complication. So consider treating that depression, and then ultimately giving them other medications for their other symptoms. Those other symptoms will go away, and then you may be able to take them off the depression medication. Okay, so that's all we have for PCOS. I know you guys have had PCOS before, but this is a women's health lecture, a women's health class. We have to address it again, so that should just be a review for you guys. All right, let's talk about infertility now. And I love this meme. I think it's so funny because that's what they're always said, right? Don't drink the water, you'll get pregnant. Because once one person is pregnant in the unit, like 5 or 6 females seem to get pregnant at the same time. So if you're infertile, you're like, oh, I'll drink all the water because it'll help me have a baby. Right? So we got our TLOs and our ELOs. In general, we think about infertility as the failure to conceive after 12 months of regular intercourse without any sort of contraception. 12 months without any sort of contraception, and we're having regular intercourse at the appropriate time. Right? And then infertility is further defined as primary infertility, never been able to have a baby, and secondary infertility, have been able to have children, but now I've been 12 months trying to get pregnant again and not able to do that. Okay. Another word that we use when we talk about infertility is fecundability. Okay. And that is the probability of getting pregnant per month of regular, unprotected intercourse. There are many factors that can lead to infertility, both male side and female side. Okay? So we want to think about this as we got to evaluate men and women as a cause of infertility. So in couples that are trying to conceive, there's about a 57% chance of success within 3 months. Okay? This increases by 15% at 6 months, so about 72. Okay, then at a year, there's about an 85% chance that if people are having intercourse at the right time, unprotected, that they are going to be able to conceive. The issue is when we go from that 1 year to 2 years, only about an 8% chance for that entire next year that these patients will be able to conceive. So that is why, yes.
Ma'am, do we know why we define it as a year or more?
This is why. Because in that first year, you're pretty likely to conceive. Okay? If you wait beyond that year, there's only 8% chance, and it only declines more and more after that. Okay? So we say 12 months because we know between 1 year and 2 years, it is not likely you'll be able to conceive without figuring out the problem or providing medication for that. Okay? It's because of the significant decrease. And because that fertility window is 5 days before ovulation through the day of ovulation, for couples that are trying to conceive, the general advice is tell them to have intercourse around that time, right? So either daily unprotected intercourse 5 days before and the day of ovulation, or every other day they can have it. Yes, if they have intercourse that often, it does decrease sperm counts, but not enough to impact fertility. Patients are still likely to get pregnant if they're having unprotected intercourse around that time. So this is a chart here, and it shows 625 ovarian cycles, 217 women that were planning on getting pregnant. A single active intercourse was recorded for 129 cycles over a 6-day potential fertile period. Okay, so around ovulation. The probability of pregnancy with a single course of intercourse on specific days range from 8% at 5 days all the way to 36% if they had intercourse on the day of ovulation. Now remember that once that egg is released, once ovulation occurs, we have 24 hours. Okay? And that's why you see this sudden decline at the end. We've got 1 day after ovulation to get it done, otherwise we gotta wait till the next cycle. Okay? So we want to talk to our patients about having intercourse around that time of ovulation, either every other day or 10 days starting before or 5 days before. And it doesn't matter what position they use. Okay? That's a myth. You gotta only do it one position, that's the best way. It's not true. They just have to have unprotected intercourse. And they've gotta not have comorbidities that are causing their infertility. So sometimes we are the cause of infertility. Okay? Sometimes it's because of the birth control pill or birth control that we prescribe to these patients. And we've talked about this before, but the different contraceptives, depending on what they're on, will depend on how long they return to ovulation after they discontinue the medication. Yes?
Would this change, like I guess how you refer somebody out for infertility treatment if they weren't on prior birth control and they're under that year cap, but they don't have a reason to really have?
So yes, it absolutely, it does. So if you say we put someone on Depo, and we already know that Depo has a potential to you not ovulate for up to 2 years after your last Depo shot. So that would be part of the evaluation and part of the consultation to say, look, they were on Depo, so you at least got to give them that year. Depending on their age will depend on if you're going to extend it longer than that, because you know in your mind that it's potential, that it could take up to 2 years. So it does impact the timeline that we're talking about for that 12 months. The main one is Depo. We know can have prolonged return to ovulation, and that's why it's important when you're placing these patients on contraception to get an idea of when do they think that they want to try to conceive. If they say I want to try to conceive within the next year, then Depo is probably not the best medication for contraception for them. Combined oral contraceptives, usually 6 to 12 weeks are going back to regular ovulation, but it can take up to 12 months for them to return to regular ovulation. So we want to talk to our patients about that when we prescribe contraception, and then we want to think about that when they're coming in now a year later and they haven't been able to conceive. Because they're going to say, I was stopped my birth control pill 6 months ago, I still haven't been able to conceive, what's the problem? And they're going to ask you to answer that question for them. So when we're evaluating infertility, we want to think about 5 basic causes. So it can be an ovulatory dysfunction. They're not ovulating. If you're not ovulating, then obviously you're not going to be able to get pregnant. And that accounts for the majority of female factor infertility. Other causes for female could be a tubal problem. We talk about tubal scarring, so fallopian tube scarring could be a uterine problem. Maybe there's something that's growing in the uterus and preventing implantation. Could be unexplained, meaning I have no idea. They've done the complete workup, labs all look good, ultrasound looks everything. I have no idea why you can't. So that's usually going to be diagnosed by our specialist, right? We're going to do our job of performing the initial evaluation. Male factor infertility, 25% of the time it's from the male. And then other, it's 9%, and that's usually associated with medication or underlying medical problems that are not well controlled. Things like thyroid, okay? Obesity, those kind of things can certainly affect fertility. Okay? Other things are in the environment. Okay, so if someone is obese, they typically will take them twice as long to conceive. And TTC is twice as long to conceive. If they're underweight, 4 times as long to conceive as someone that has normal BMI, normal weight. So if they're coming in, they have obesity, I would think about things like PCOS. Look for hirsutism, look for that excess acne. Okay, if they're underweight, maybe we think about things like anorexia. Sometimes bulimia will come in being underweight. So the female athlete triads. We want to think about underlying causes as you're talking to these patients. Alcohol, smoking, illicit drug use. Okay? That has a reduction or a risk of infertility of 1.5 to nearly 2 times compared to people that don't smoke or drink or use illicit drugs. Okay? And then caffeine consumption, more than 250 milligrams a day, 45% decrease in fecundability. So fecundability is the likelihood of getting pregnant in a month of regular intercourse. 45, 250. So that's, if you're a coffee drinker, that's 2.5 cups of coffee. And not the Starbucks coffee. This is a regular old coffee. And so we think about other things that have caffeine. Tea has caffeine and sodas. So that's not a lot of caffeine, to be honest with you. So patients often don't equate caffeine and infertility, but there's a direct correlation. And we talk about smoking, we're not just talking about active smoking, we're talking about passive smoking as well. Both of them increase infertility rates. So if the woman doesn't smoke, but the male partner does, then we always have increase in that infertility rate. We also want to think about the fact that smoking damages material in the egg and in the sperm, increases the risk for miscarriages, increase the risk for birth defects as well. Even smokeless tobacco can affect infertility. Women that smoke are more likely to conceive chromosomally abnormal, have abnormal pregnancy, something like a Down syndrome. Okay, and there are different forms of Down syndrome. Ectopic pregnancy, preterm labor, all of that is associated with active and passive smoking. Okay. Even patients that are undergoing fertility treatments, okay, they have increased rate of it being less likely to be successful if they smoke, okay, and about 35% chance of failure when compared to non-smokers. So we talk about the male sperm. That's also affected by smoking. Decreased motility, decreased sperm count as well. Okay? And really it's all about endothelial inflammation that's associated with the smoking and nitrous oxide. Okay? Alcohol consumption, that can certainly reduce the chance by about 15% when we compare to non-drinkers. It also contributes to erectile dysfunction in males and decreased sperm counts in males. Illicit drug use, that reduces fertility rates. Overall, these drugs tend to decrease fecundability, okay, just like we talked about with caffeine. Marijuana suppresses the HPO axis, okay? Cocaine, y'all know I love cocaine, right? Adversely affects spermatogenesis. So it also, we talked about an EKG, it affects the heart and the coronary arteries. Well, now it's affecting infertility as well. Told you it was bad. Caffeine, we already know, in moderation, less than 250. So unfortunately, they've got to look. I don't know how much. I don't even hardly drink caffeine, so I don't know how much caffeine is in anything. Do those little energy drinks, do they have caffeine in them? No? Some? Maybe? Yeah, I don't know. I think my heart would explode if I ever had one of those drinks. So when do we work these patients up? We already talked about the 12 months, right? That's for the majority of our patients. 12 months, they're coming in, they come in at 9 months, I can't conceive, I'll see you back in 3 months, okay? But if they're between 35 and 40 years old, okay, 6 months is typically our recommended threshold. 6 months. Over the age of 40, immediate evaluation. Not immediate consultation, but immediate evaluation. Let's start our job first, and then we can ultimately can refer these patients to a specialist if needed. And we all can kind of understand why it is. The eggs don't last forever, okay? And so as we know, we're born with all these eggs, but as we hit puberty, the eggs have already decreased significantly. Only 400,000 eggs left. By then, we started with 2 million. Okay, so by the time we get to 40, there's not a lot of life left in those eggs. We want to try to get these patients evaluated and treated a lot quicker. And when we evaluate these patients, we've got to make sure we do a good medical history. We've got to make sure that includes a good reproductive history. What about any history of STI? We've got to do a physical exam on these patients. And then sometimes, based on their history, based on their physical exam, we're going to need to do additional testing. Blood work, maybe ultrasound, especially for the female. For the male, we talked about doing a sperm sample as your primary, or semen analysis as your primary means for evaluation for male factor infertility. So think about the environmental factors as well. When we talk about males, okay, look for evidence of decreased testosterone. Let's see if they have, they don't have much hair growth, or if they have issues with erectile dysfunction. And ask them about history of STI. When was the last one, if you've had one? When was it treated? How many have you had? What were you treated with? Did you complete your medication? So if they have repeated STIs, that really affects the vas deferens, right? And so now the sperm can be transported appropriately. History of mumps. A history of mumps can lead to testicular inflammation. That can damage their spermatogenic stem cells. Okay. Testicular trauma, history of testicular torsion, A history of undescended testicles, and that can also cause abnormal spermatogenesis. We want to examine these patients for varicocele. There is a thought in some of the literature that varicocele will increase scrotal temperature, and that can lead to fertility issues. And then look at their medications. Look at their medications. Are they taking steroids? If so, how much and how long have they been taking them? If they've been taking kind of a higher dose of steroids for quite some time, it decreases sperm count, and unfortunately, sometimes that can't be overcome. That can't be undone. Have they ever sired, or have they ever retired pregnancy before? Do they have other children from prior relationships because they can't have one now? And then when we think about the sperm, we want to think about spermatogenesis and the time period for spermatogenesis. Okay? 90 days. 90 days for spermatogenesis to be completed. Any detrimental effect during that 90 days, that's going to ultimately potentially affect semen characteristics. And since spermatogenesis works best at temperatures below normal body temperature, if we have increased risk in testicular temperature, like maybe it's in the middle of winter and they're in a hot tub every day because they're trying to relax. Right? Or maybe they got sick with the flu and they had a high fever for several days. Maybe they had mono. Anything that increases testicular temperature, that's going to affect sperm quality. Medications, erythromycin, tetracycline, TCAs, SSRIs, all of those can affect semen characteristics. So you've got to look at their medications. Is that for me? No, not for me. Okay. See, do they have primary hypogonadism? Okay. That certainly can impair testicular function. That affects spermatogenesis. And then smoking, we've already talked about that affecting spermatogenesis. So you've got to think about not just today, but what's going on in the last 90 days that could affect these patients. So for the male partner, it's going to be semen analysis. That's going to be the cornerstone of fertility evaluation once we get their history and physical exam. Now, it's important because you guys will often be referring these patients to the lab. You're going to be writing the order for a semen analysis. I did it many, many, many times when I was in primary care. So you got to remind them to abstain from ejaculation for 2 days prior to them going to give the semen sample. And where is the semen sample done? In the lab bathroom. Okay? Because as soon as they get done, they hand it to the lab tech, and within 30 minutes and no more than an hour, they've got to look at the semen under the microscope or however they do it nowadays. And they've got to document that within that hour time frame. Usually it's 30 minutes. Because after that, then the semen the sperm starts to die off. Right? So it's really important. No ejaculation for 2 days before. They go to the lab with their little magazine, and then they give the sample, and then out they go. Now, if the semen analysis is normal, they get to do this again in about 4 weeks. All right, so usually they wait 4 weeks. Some literature will say 2, but a lot of literature nowadays say about 4 weeks. And they come back and they get to that same bathroom and they do it again. They give the semen analysis to the lab and then out they go. So once you have 2 normals, you're good to go. If you had an abnormal, now we've got to get 3 specimens, okay? So they're going to become really familiar with the bathroom and hand that off to the lab tech and shake their hand, thank you once again, and out they go. So you will be ordering all of these subsequent tests as a primary care. When I was doing these evaluations, we did have from urology and from OBGYN like a pathway for infertility workup on what we were supposed to do from primary care, and then ultimately reasons to refer. So make sure that you understand where you're working, what the reasons are to refer. Because if you refer these patients and it's not following the guidelines, they're not going to see them. Yes, sir.
Ma'am, for the normal versus abnormal, does that mean they need 2 normals in a row or 3 abnormals in a row? So like if they have like normal, abnormal, you just keep bringing it back in?
Yeah, so you have to have, so if you have a normal and then the next one is an abnormal, now you've got to do another. So you've got to have at least 2 normals. right? So if you had normal, abnormal, and then the next one's normal, then they most likely would say, okay, we're good to go. Okay, there is a potential they say, no, we want one more normal, so you have two normals in a row. If you have abnormal, then normal, then we need another one. If it's abnormal, then they're gonna need another one. So it does kind of, yeah, you could ultimately be 6 semen specimens, but usually after the 3, if we're like, we're not really sure, then that would also be a lot of times guidelines to refer to a urologist to figure out what's going on here. All right, let's take a break. Semen analysis, you don't need to know all of these normals or all that. You know, you're gonna have 2 normals, normal parameters. You don't have to know the amount or the count or all that. Know that you need to have 2 normals or 3 abnormals. And then one of the students said, you actually don't have to do it in the lab nowadays. You can do it at home, yay! But you still have to have it to the lab within 30 minutes so they can evaluate it. So that probably makes it a lot more comfortable. All right, so that's it for the male. That's it for the male. We do a semen analysis, we do a history physical exam, and see if that's part of the problem. 25% chance that it is a male factor problem. The rest of the time, we think about female factor infertility. So first thing we want to know, is the female patient ovulating? Is there evidence that they're ovulating? And if they're having a regular menstrual cycle, that's kind of evidence that they're ovulating, because we talked about anovulation associated with irregular menstrual cycles. So if their menstrual cycles are regular, you think, oh, probably not an anovulatory problem. If they have what's called middle smirts. So middle smirts is pain on the side, the adnexal that the ovary is ovulating. Usually it's going to be mid-cycle pain, and that happens with patients, and a lot of patients don't have this at all, but some patients do. But if they have it, it's like, if I'm in the middle of my menstrual cycle, I start having a little bit of pain on one side or the other, well, that's often associated with middle spurts, and that's evidence that they're ovulating. They might also have things like breast tenderness or acne outbreaks during that time period, food cravings, mood changes. Those are all associated with increase in progesterone, which indicates that they're going into that luteal phase, and oftentimes tell you that they're ovulating. And then other things that we think about, peripheral edema, abdominal bloating, maybe increase in vaginal secretions, all those things might give you an indication that these patients are ovulating. Isn't this a really cool picture? So you got your ovary, you've got your follicle, and look, the egg out. That's amazing to me how they even got that picture. But we were talking about, nowadays when they do assisted reproductive technology, you can even kind of choose the sex of your baby. It must have to do something with this process. We pull everything out, we examine it under the microscope and figure out what to do to make it male or female. Other ways that we can figure out if our patient is ovulating, we can use something called the basal body temperature. And basal body temperature, the patients just track their morning temperatures, they put it on a calendar, and they try to identify a couple of days where they have a sustained increase in their body temperature. And once they do that, they backtrack a couple of days, because a sustained increase in the body temperature means they've already ovulated. So that's kind of a complication with using basal body temperature. It's a post-ovulation temperature that causes the increase. Anybody have any idea what causes the body temperature to increase? Progesterone. So that's a definite indication that they're going to the luteal phase. So that an increase that comes from progesterone. And so this is what it might look like. So every day, before they get up in the morning, they take their temperature, they chart it, and usually it takes about 3 months or so from charting their body temperature for them to figure out exactly when they're ovulating. And it's going to be that increase in temperature. So here we kind of go up and down, but now we've got this significant increase, and we're looking at about a 0.4 degree increase in Fahrenheit in their temperature, and then it's sustained. We have stays up here. At the end of that luteal phase, it's going to go back down, and then we start our follicular phase. So we have a sustained increase. Again, they'll back it up by usually 2 to 3 days, and that's going to be the time period in which they ovulate. So it takes a couple months for them to figure that out. and they can have intercourse around this time, and then that day after their increase in temperature. There are over-the-counter urinary ovulation kits that detect the LH surge. So women typically will begin testing about 2 to 3 days before they anticipate they're going to have the LH surge or the ovulation. And remember about the LH surge first? So the LH surge occurs because of the increase in estrogen. So really it detects increase in estrogen and ultimately that increase in LH, usually about 12 to 36 hours or so before they ovulate. Okay, so the idea is if they can detect the LH surge, they know they're going to ovulate in the next 1 to 2 days. So they got to detect that first, and then they have intercourse around that time. So those are available over the counter. But the key is we've got to identify if they're ovulating. Another way of identifying that is maybe even just doing a serum progesterone level. Since we know that in the luteal phase, they have an increase in that serum progesterone. So this is actually a much earlier detection, of course, than the basal body temperature. And it's probably a better test than the over-the-counter LH surge, urinary LH surge kits. Once they have this, if the progesterone level is elevated, it's about 80% chance that the ovulation has occurred. So usually when they detect this, it's going to be in the mid-luteal phase. So the recommendation is you'll send them between days 19 and 23 of their cycle. So you count from the beginning, the first day of their menstrual cycle, and 19 to 23 days later, you want to send them for a progesterone level. And this tells us if it's elevated, so greater than 3, the patient is ovulating. They're going, or at least they ovulated that cycle, they're going into that luteal phase. If it's less than 3, then that indicates something called a luteal phase defect. They're not getting to the luteal phase. They are not ovulating because their progesterone levels are too low. We should see increase in progesterone levels at that 19 to 23 days. But it's really key those days, 19 to 23. Because if you wait and you do it earlier on, if you do it earlier on, if you end up doing it in the late follicular phase, we don't expect our progesterone level to be elevated, so you'll get a false reading, won't give you a good idea if you're ovulating or not. If you identify, like, gosh, I really don't think you're ovulating, we call that anovulation, or if they're not ovulating regularly, so let's say you did this progesterone level, you did it 3 months in a row. In 1 month it was elevated, the next month it was down, the next month it was elevated, but they're not ovulating consistently. Now we want to kind of expand our differential and look at other causes. Is it a thyroid problem? So check your TSH or your thyroid function test. Is it something wrong with the pituitary? You need a prolactin test. Let's look at FSH. Maybe these patients have premature ovarian insufficiency. And maybe their ovaries are not functioning as they should for this state in their life. So we gotta check that FSH. If it's elevated, that would be concerning. Again, if they have evidence of hyperandrogenism, nothing wrong with testing a total testosterone, free testosterone, and then DHEAS is also, especially in the face of utilization of hyperandrogenism. One of the factors that affect infertility is tubal factor infertility, so something wrong with the fallopian tubes, and another one is there's something going on with the uterus, so it's maybe preventing implantation. So we think about maybe congenital abnormalities with the uterus. Maybe there's something like a leiomyoma, maybe they have endometriosis, maybe they have adenomyosis, maybe there's scar tissue that has developed. Okay, so we can evaluate those things with an ultrasound. Okay, if something's distorting the cavity like a leiomyoma, it might hinder sperm moving, it might hinder implantation. Certainly, if the tubes are not patent, that's going to hinder implantation. Okay, maybe the fallopian tubes have significant scarring. So all of that's going to affect fertility. So we can do an ultrasound to initially evaluate that. You might do something like an HSG. An HSG is a hysterosalpingogram. And for them to do a hysterosalpingogram, what they will do, they will go in through the vagina, go in through the external os, and then they'll put a dye into the uterus that goes out to the fallopian tubes. okay? And they're looking to see if there's anything abnormal in the uterus and if the fallopian tubes are patent. We could ultimately do a pelvic MRI. That's typically going to be done by the consultants. And then obviously a laparoscopy, especially in the setting if we think this is related to endometriosis. And that would be, remember, laparoscopy for endometriosis is not only diagnostic, it's therapeutic. And if they're able to treat that, then it significantly increases these patients' chance of being able to conceive. This is an example of a hysterosalpingogram. So on top we have a normal hysterosalpingogram. This is coming in through the external os, internal os, up into the uterus, and they inject this dye, and the dye then goes out to the fallopian tubes out here, and so we can see that we have dye that's coming all the way out, and dye that's even coming outside of the fallopian tubes. So that tells you that the fallopian tubes are completely patent. It's all the way out into the periphery. Okay, now if we look at this one, we come up, we've got dye that comes in, but this uterus does not look like this uterus. This uterus looks kind of scrunched down and abnormal appearing. It did not look like a nice pear, right? So this person probably has some sort of scarring in the uterus. It could be, this is an Ashman's, it also could potentially be from something like endometriosis, but their uterus is scarred down. Baby's not going to be able to implant in that. Okay, and definitely if it can implant, it's probably going to end up in a miscarriage because it's not going to be able to grow. Okay, and then we come here and we come up. Uterus actually doesn't look too bad, but what do we see here and what do we see here? We see a little bit of dye extravasation here, but otherwise it looks like that dye is held right into the fallopian tube. That's probably some sort of scarring down of that fallopian tube, maybe a history of PID, maybe STI, maybe some sort of fallopian tube tumor even. So we can see that with our hysterosalpingogram. Again, even from a primary care perspective, I have ordered many of these hysterosalpingograms from primary patients. Okay. I recommend wherever you're going to be working after phase 2 to just figure out what the pathway is for your purposes and how much you're supposed to work these patients up. And there will be some places that you don't work them up at all. Fertility specialist wants you to do all of the things. And there's other places that you have to do everything all the way up until they can get fertility treatment. So you just have to figure that out. But if we think about these 5 main etiologies, we talked about with the male, we talked about semen analysis, we talked about figuring out if they're ovulating or not. Okay, we talked about tubal or uterine factors by doing an ultrasound, HSD, maybe ultimately a laparoscopy. Okay, the unexplained, that's up to our consultants. Oftentimes we can't figure that out unless we have evidence on labs that are abnormal. And then we've got to look at their medications and their medical history associated with that. So that is our workup for these patients. Okay? Now, the other thing we have to think about, so if they're ovulating regularly, infertility can still occur because of the reduced quality or quantity of the follicles or the eggs as a woman ages. So when we think about associated with age, we think about because these eggs are now decreased quality, decreased quantity, we have increased risk of genetic abnormalities associated, increased miscarriage rates significantly, overall decreased pregnancy rates in women starting as early as the mid-30s. And that's why we do 35 to 40 is 6 months before when we start the evaluation, and not that 12 months. Okay? Overall miscarriage rates for people over the age of 40 is much higher than we see people 20 to 29. 8% versus 50 to 75% miscarriage rate. So we want to set these patients up for success by evaluating them earlier on in their infertility process. So how do we assess these eggs? How do we assess the quantity, the quality? What is the likelihood? Because if they have no other risk factors, we have to turn to, is this an egg problem? Okay? So we can do that by assessing something called ovarian reserve. So ovarian reserve, what we'll do is on we call them day 3 labs. We'll check for FSH, we do LH, we do estradiol levels. So day 3 labs, what does that mean? Menstrual cycle started on day 1. We got day 2 of the menstrual cycle, day 3 of the menstrual cycle, that is considered day 3 labs. Okay? And we are doing that during this time because it seems like, through all the literature, that the hormones are kind of the most stable on this day. So we send these patients for day 3 labs, and if we get back a high FSH, a high LH, that tells us that the ovaries are not responding well, right? So we've already talked about pituitary down the ovaries. High FSH, LH tells us the ovaries are not responding as well as they should for this person at this time in the reproductive life. Okay? If we have a high estradiol level, so high estrogen level, that's the E2, okay? Then that is also concerning because high estrogen is going to negative feedback. It's going to come back to the pituitary, shut down FSH and LH, and now we can't get those follicles to produce. Right? So we don't want that. We don't want high FSH and LH. We don't want high estrogen levels or estradiol levels. We want them to be normal, and even if they're a little low, we can tolerate that. But the high tells us we have decreased ovarian reserve. Okay. Another thing that has become really part of standard practice in the last 5 years is checking an anti-Müllerian hormone. I know some of you guys are thinking, wait a minute, I remember hearing anti-Müllerian. Doesn't it have to do with men? Yes, it does, but women also have anti-Müllerian, little bit of anti-Müllerian hormone. And they're located, guess where? In the eggs, in the follicles. That's where that hormone is located. So we're going to check an anti-Müllerian hormone, and usually you can check it at any point because it's relatively stable hormone throughout the entire menstrual cycle. But because they're getting labs on day 3, just throw it in with the day 3 labs. So an anti-serum AMH level, we're going to put that in there. Now, it will decrease at a normal rate as a patient gets older. We know that. Okay? But when they're really low levels, less than 1, that tells us this patient has a diminished ovarian reserve. You're going to see that more in postmenopausal patients. We shouldn't see that in reproductive age patients, not that low. Okay? So again, add that with those day 3 labs, FSH, LH, and then estradiol levels. We'll add that serum anti-Müllerian hormone in there as well. Okay? Another thing that they often do will be an ultrasound. And that ultrasound is going to be usually transvaginal, and it's going to assess the follicle reserve. Okay? And usually we will do this on day 3 along with the labs. So they'll go to labs, they'll get their day 3 labs, and then they'll go to ultrasound and they'll get their day 3 ultrasound. The primordial follicles are microscopic, so they can't really assess specifically the primordial follicles. But what they'll look at here is something called the antral follicles. You can see those. And ideally, these patients will have more than 20 antral follicles, which means they have more than 20 primordial follicles that are ready to become the dominant follicle. Not all 20 of them are going to be, dominant, but we want at least one of those to be dominant. But if we start off with less than 5 to 7 of these antral follicles, that tells us we don't have very many primordial follicles that are even ready to be the dominant follicle. Okay? So this top one is what we want to see. We want to see all these highlighted areas. We have all these follicles that are popping up. The bottom one, we have 1. We have 1 antral follicle. Those patients are not likely to get pregnant because they don't have enough follicles to even get pregnant. Okay? So if they don't have enough follicles, we've got to make them have enough. I'm going to help them increase their follicle count by giving them IVF, by stimulating the follicles. Okay? So when someone comes in to see you for infertility treatment or infertility evaluation, let's look. We have indication that they're ovulating regularly or not. Okay? If we don't have evidence of anovulation, then you need to look at those labs for anovulation. Are they having intercourse at the right time period? If they're having intercourse 30 days out of the month, well, that's going to significantly reduce the sperm count and probably not increase their chance of conceiving, right? Yes, around the time of ovulation, frequent intercourse is good, but not 30 days out of the month. You're going to do your history, you're going to do your physical exam, maybe you'll send some vaginal swabs and make sure everything is okay there. Send male partner for a semen analysis if it's indicated. Okay, and most of the time, even if they have had prior pregnancies, that'll be part of the evaluation. And then we look at labs. Basic labs are okay, CBC, basic metabolic panel is okay, urinalysis. maybe a thyroid, prolactin, testosterone, DHEAS, depending on your history of the patient, the physical exam. We've got those day 3 labs and ultrasound. Maybe if there's any evidence of tubal factor infertility or something going on with the uterus, where they've had dysmenorrhea, they've had irregular cycles, maybe we do that hysterosalpingogram as well. Okay. And then our referral. 12 months for those less than 35, 6 months 35 to 40, and then less than 6 months over the age of 40, we're going to refer those guys immediately. Treatment, of course, is going to depend on what is the underlying cause. Okay. Ideally, we want these have these patients at the normal body weight, talking about routine exercise, eating a healthy diet, and then treating appropriately any underlying medical conditions that they have. If they have thyroid, check that TSH. If their TSH is too low, you got to treat it. If it's too high, you got to treat it. And you can manage thyroid normally from a primary care perspective. A lot of times, the end result is they need some sort of fertility treatment. So we will give them as an initial treatment, especially in anovulatory cycles, clomiphene. Clomiphene citrate is a really common medication that is used in fertility treatments. It is a SERM, and what it does is increase FSH levels and ultimately, hopefully, increases the follicles that are in the ovary, the number of follicles. When we give clomiphene citrate, they usually will start it on day 3 or 5, and then the medication dose will depend on the patient's body weight. So usually 50 milligrams a day, and that can increase to 100 milligrams. If you've tried that for 3 to 6 months and still they don't seem to be ovulating, they haven't gotten pregnant, then that's a time to refer. And you may or may not be giving these medications. A lot of things nowadays have been pushed to the primary care setting, even in the military, because these subspecialists will only see the worst of the worst cases. So you may, in fact, be treating these patients. Okay. Other things we want to think about, especially in patients with PCOS, metformin is a good treatment. It helps with PCOS, with the abnormal glucose levels and insulin resistance, but also it seems to increase the chance of spontaneous ovulation. There is no direct correlation that it increases live births in patients with PCOS, but it certainly helps them with their ovulating regularly and increases their chance of becoming pregnant. We have things like gonadotropins, HCG injections are pretty common nowadays, Pregnyl, Gonad-F. It really depends on where you're working on what that specific subset of specialists are going to use. Aromatase inhibitors, letrozole, just like we talked about with PCOS, can be used. And then ultimately, even in the military setting, they can do assisted reproductive technology or ART. If you are prescribing these medications, and it's usually associated with the injectable medications, but if you're prescribing these medications or following up with patients that are on these medications, you need to be aware of something called ovarian hyperstimulation syndrome. So here the medications work great, they work too great, and the ovaries are hyperstimulated, and they'll come in with lower abdominal pain, discomfort, because the ovaries are getting bigger and bigger and bigger because of the number of follicles that these medications are creating in their ovaries. Their symptoms can range from mild to death. Okay, so that's a wide range, and we want to avoid the death part, right? So these patients, when they come in and they're on these medications, they have lower abdominal pain or discomfort or bloating that is unusual for them, and they need an ultrasound. That's really the way that you're going to identify ovarian hyperstimulation syndrome is on an ultrasound. The treatment is to either lower the dose of the medication that they're on or completely stop the medication. And that's really hard from a primary care standpoint because we try not to stop medication that our consultants put these patients on. We like the consultants to do that. But if you're on a Friday evening, over the weekend, these patients have this, you're able to diagnose it. It may be the fact they have to stop the medications for a couple days, if you can't get a hold of the fertility folks. Again, depending on where you work. But ultimately, we've got to decrease the amount of medication in their system, which will then allow those follicles to go back down into size. And sometimes these patients do need to be admitted to the hospital, especially if they have those severe signs and symptoms. And this is what it might look like on an ultrasound. So remember, ovary is very, very small, 3 to 5 centimeters. Well, these are ovaries that are meeting all the way in the middle of this patient's abdomen. So they're kind of pushing, even pushing the uterus down, is how big these ovaries are. And we've got large areas. So these are follicles that are super, super large. So you may have increased number in follicles, but you also may have 1 or 2 follicles that just continue to grow and grow and grow and grow because of the medication. Certainly, you can have decrease in blood supply because of the enlargement of the ovaries, so they are going to check for that. Because these are so big, sometimes because they're so big, they don't even have room to twist. But if they're not, they could result in ovarian torsion, so that needs to be on your differential. These patients, especially at a sudden onset severe pain. So just something for you guys to be aware of. Now, in 2014, they started doing uterine transplants. Okay? So if someone has a uterine factor infertility, so they're either born without a uterus or they have, they ultimately had the uterus removed for some reason, they could actually get a transplanted uterus, but they do need to have ovaries. They have ovaries. So they'll transplant the uterus, the cervix, they'll transplant the vaginal cuff, all the ligamentous and the vascular structure, all that will go into the patient. They gotta have their ovaries, and the ovaries have to be functional. And then they will inseminate, usually via IVF, and then ultimately these patients can deliver via C-section. So there's been about 120 or so uterine transplants, successful uterine transplants in 2014, and about 70 live births. And the really nice thing is this is temporary. They'll allow them 1 or 2 pregnancies, and then after that they'll remove the uterus. While they have the uterus in, they will need to be on anti-rejection medications, but once the uterus is removed, they can come off those anti-rejection medications. So this is something that is done, I don't know specifically in the military, but certainly the military will pay for something like this for patients that meet these criteria. And usually this is not something you're referring them to, but I just think it's pretty cool for you all to know that this is out there, it's available. Okay. All right, that is it. Good luck on your exam tomorrow.